Good morning, good afternoon, and good evening, everyone. Thank you for joining us for today's last PATH live forum of the year, titled Truly Global Health, International Lessons for U.S. Health Systems. My name is Cyril Engmann, and I'm the Senior Director of Program Quality and Impact at PATH, as well as I'm an attending neonatologist at the University of Washington and a Joint Professor of Pediatrics and Public Health. I'll be facilitating the discussion today. Just before we start things, though, I want to go over a few logistical issues. First of all, we'd very much love to hear from you during this conversation. So please share your questions and comments with us by submitting them in the chat or Q&A box at any point during the webinar. We have some time later in this session to answer some of those and to really embark on the Q&A. And let's start things off by figuring out where people are calling in from. So if you can type in what city and what country you're tuning in from today and what the weather is like, let us know and hit send to everyone so we can all hear this. Another little housekeeping issue is that this webinar is being recorded and will be made available to those unable to join us today, and the recording will be distributed tomorrow as well. So, without much ado, I'll begin by introducing our panelists, and then I'll briefly frame our conversation before diving into the questions. We are truly in for a treat. We have four incredible panelists who will be joining us and who will be speaking at different points today. The first is Katie Bollbach. She's Executive Director of Partners in Health. And Katie is, and many of you know, Partners in Health, and this is particularly the US arm, is a nonprofit global health and social justice organization. And Partners in Health US works to advance health equity in the US by accompanying visionary public health and community leaders to build more just systems and healthier communities. The next person we have is Kristen Peterson, JD, who's Chief of Policy at the Washington State Department of Health. Many of you know that the Washington State Department of Health has really been one of the first, if not the first, to prioritize global health and One Health. And this is something that we're really looking forward to hearing Kristen talk to us about. She certainly worked very, very closely on developing much of their transformational plan, which is really extraordinary. And you'll hear about this in a little bit. And then we've got Tremmel Freeman, who's the Chief Executive Officer of the National Association of County and City Health Officials. So Laurie has been CEO since May of 2018. And in that capacity, she works to ensure that nearly 3,000 US local health departments have the capacity to deliver essential health services to their communities, advocates for local health, public health within the US global public health system, and also assures strategic alliances and partnerships with a wide variety of federal, state, local, public, and private agencies and organizations to advance health in the US. And then finally, we have a guest appearance by Dr. Umer Shah, who's Secretary of Health for the great state of Washington. And we're hoping that he'll be able to join us probably at the early part of this session to say a few words. And we're just thrilled that he'll be able to join us, as well as Kristen, Laurie, and Katie. So first of all, a big thank you to our panelists. Now, to quickly frame our conversation, I think for all of us who've been on the planet over the last 3 years, it's been a tumultuous time, to say the least. And it has become so evident that what happens in one place within a few hours can have incredible resonance, positive or negative, in another entirely different geography. Public health challenges like cancer, diabetes, mental health, faced in one region in the world, have exactly corollaries, challenges that are seen in other parts. And so our shared sort of global health experiences are really only expected to increase as the world continues to navigate more problems, as we begin to discover and describe perhaps even more accurately the impact of climate change on individuals and on community health. And so this provides, I think, all of us an opportunity to better prepare and address both known and unknown threats, both known and unknown as well, in the US, and to leverage some of these lessons that we've learned globally into the US domestic space. To give you an example of how these things have played out from a practitioner's standpoint, there was absolute pandemonium 3 years ago when we started seeing cases of COVID-19 in the ICU. And within the space of hours, we were frantically connecting and contacting colleagues from all over the world who were perhaps seeing this a few hours earlier than we were, and who were sharing what was working and what wasn't. There was just such a franticness about it, and such a communication that was necessary, and such learning that was actually happening very much from a global to a US setting. That was at an individual practitioner level. At a county health level, many of us utilize the train-the-trainer models that we have used countless years and countless times in many other contexts to be able to train healthcare workers, community-based healthcare workers, particularly in the state of Washington, to go around and to better disseminate the right sorts of information around what we were learning with the pandemic. And even at a national level, I was privileged to serve on the advisory, the president's advisory group on vaccines and vaccine development and the COVID vaccines. And it was a tour de force of effort to have vaccines developed over the space of 9 to 18 months that we saw. And it didn't just happen in isolation. We were, again, in close contact with a number of other groups, a number of other countries who were working together. It was truly a global and collaborative effort. So today, our speakers will highlight some of the ways that we can take and what we've learned in global health, and how we can apply to some of the challenges that we are seeing in the US today. So I'll start off by asking a very general question, and then we'll kind of take it in turn from there. So each person has had extensive public health experience, each of our panelists. And so from our perspectives, we want to hear from you. What does globalization look like in a US public health context? And how can we benefit from global health best practices in the US? And I think if we've timed this right, we may actually ask Dr. Shah to kick this open. Is Dr. Shah on the line? Perhaps not. So he may join us in a little bit. But let me open this up to our panelists. For each of you, from your perspective, what does globalization look like from a global public health context? Perhaps I'll kick off with you, Katie.
Thanks, Cyril, and thanks all for being here. I think, for us at Partners in Health, we've for a long time worked across a network of sister organizations around the world that have continued to learn and support each other in advancing health equity in diverse political and economic and social settings. I think, and I've spent most of my career until fairly recently working outside of the US, but I think oftentimes folks lift up the United States as a place that has, the best, most innovative healthcare in the world, or we're a country where, we spend more than any other country on the planet on healthcare and health, $4 trillion a year. It's 20% of our economy, which is pretty extraordinary. And yet we are getting worse health outcomes than our peer countries, and yet, and in aggregate. And then within that, we have these really severe and persistent inequities by race and ethnicity, by class, by, there's just so many different historically and actively marginalized groups in the country that are having severely worse health outcomes across the board. And so I think, COVID really, or we saw, even more painfully during COVID, the kind of very fundamental challenges and weaknesses that we face in our health systems here in the United States. And I think the moment of kind of attention that this crisis has allowed us to kind of draw a broader set of folks into a conversation about what we here in the US need to be thinking about and learning about from others around some more fundamental upstream systems changes and policy changes is a real, I think, exciting opportunity to kind of push some more ambitious and imaginative thinking. And we found, I think, that while we may have more money in the system here and more clinical resources in this country than almost anywhere else on the planet, that we actually have so much to learn from our colleagues in countries or working in systems that may have way fewer resources, but are working and building systems that are much better designed to care for the most vulnerable and to really, take an equity-centered and community-driven approach, kind of top to bottom. And so, I think there's, from a programmatic and technical perspective, a lot we have to learn and are trying to carry from our work and colleagues in Haiti and Sierra Leone and Peru here to our work in the US. But there's also a kind of solidarity component. One of our co-founders, Paul Farmer, used to speak often about kind of failures of moral imagination, that we have sort of technical failures and gaps, but I think being able to continue to build broader global solidarity here in the US with global colleagues working on the same equity and health justice challenges is, I think, a really key need and opportunity we have right now.
Wow. Thank you for that. Thank you for that opening thought. Laurie.
Hello and good morning or good afternoon, wherever you are. It's great to be with you all today. From our perspective, which is, it has traditionally been highly focused domestically in service to our governmental local health departments. As Katie mentioned, our country has lowest life expectancy at birth, the highest death rates, avoidable, treatable conditions, highest maternal and infant mortality, high teen pregnancy. There are so many areas related to public health that are dealt with at the community and jurisdictional level, where we've had long periods of time where the outcomes have remained poor despite the interventions that have been introduced. They're not improving. And I think it's time for us to really scrutinize and take a close look at the interventions that aren't working and really reevaluate them given some of the failed outcomes or improvements that we're seeing. And for us, there is much that other countries are doing, including low and middle income countries. Countries that have different types of health systems that don't look like us, but that can teach our country's local health departments how to improve persistent health challenges. We believe that global health offers some unique examples of really innovative, cost-effective approaches to some of the most vexing health challenges. And these opportunities really provide openings for us to look at diverse interventions and perspectives from other places. Take a look at how we have access to a slate of demonstrated and really evidence-based approaches that we believe can be adapted to achieve the results that we're not seeing with our current interventions. These global health programs often have been developed and tested in low resource settings, which makes them more affordable and adaptable. Half of our country is supported by local health departments that are serving really small and rural areas of our country. And so the settings aren't all that different, although certainly we have a lot of challenges with our healthcare system as well. But especially for our rural areas, these practices can really be helpful. And also, as we see migration patterns change and a need to really serve our refugee, immigrant, and migrant communities differently, these practices also provide an opportunity for a different way to approach cultural and linguistic challenges that might exist in communities or where local health departments may not have the skills. And some of these solutions really offer that framing for us and can be used. We also really enjoy the fact that these global solutions, many of them promote partnerships and promote community-driven, community-led health initiatives that are done in conjunction with the community, with their voice always at the table to really foster that community engagement. So there's so much promise here. And our country has been rather egotistical about its approach to health interventions. And even though we are the most advanced country in the world, we have a lot that we can learn from less advanced or developed countries that care for their communities and their people differently.
Thank you. Thank you for that. Kristen, what about you?
Yeah, good morning. Thank you for the opportunity to be here, and welcome to everybody from across the globe, it looks like, according to the chat. Full-heartedly agree with the comments from Katie and Lori. From the Department of Health's perspective, we have a real interest in what we can learn from global practices centered on the themes that we just heard. Innovation, globalization means centering community and equity. I have a keen interest in how we can innovate policies and practices that improve health. And I think I heard the the term egotistical. We have so much to learn from other countries that may have less resources. They may be they have innovative approaches to the workforce with the community-based workforce. There are a lot of similarities to Washington State, for example, when we look at disparities across the state. It's unfortunate across the nation where zip code still determines health outcomes. So we have much to learn from other countries on how to deploy effective and culturally responsive efforts that improve health outcomes. So just really, to me, globalization means elevating that this is a priority, and that does motivate change and innovation.
Thank you. Thank you very much. And you've clearly spent the last few years working on the state of Washington's transformational strategy, which includes very much a large part of this, doesn't it? And we'll come back to those comments in a little bit, Kristen. But let me pick up from a few things you said, Katie. And maybe I'll frame this by saying we know that PIH has been doing incredible work in different countries. And can you speak a little bit to the impetus to start work in the US, and then how PIH linked its global and US domestic agendas? And whilst you're answering that, because we can, what were some of the key considerations, challenges, and solutions that you considered as you developed this domestic agenda? We'd love to learn a little bit more. In the past, you've talked about some very striking ethical considerations, and we'd love to learn more from you.
Sure. Well, we have had a longstanding partnership with a sister organization in Navajo Nation here. And so that had been, our primary work in North America previously. But when COVID, when early 2020, we saw COVID coming, we were working with our country programs around the world to train community health workers in IPC, to ramp up oxygen production, to kind of think about ICU capacity, and then found ourselves at the epicenter of the pandemic here in the US. And so felt called to see, where we could pitch in and support response efforts here, particularly given how challenging those early days were, as you mentioned. I think, we've done emergency epidemic response work in I worked in West Africa on the Ebola response for several years, worked on cholera in Haiti and et cetera. But, I think in digging into that work, of course, we knew that COVID was really an acute on chronic crisis. So the reason that COVID was such a disaster here was not just because there were elements of it that were unprecedented, but because of the sort of fundamental challenges that we've spoken about in our health system, in particular, the lack of investment and prioritization of public health, community health, primary care, some of those basic building blocks of strong health systems and healthy communities. And so, we, as we do all over the world, I think really go where we're invited. So that work really began in Massachusetts, where we have kind of a home base here, and then wound up spreading out to partner with the state and local health departments around the country, as well as community organizations and kind of other coalitions around the country. And so, initially it was a COVID response kind of initiative, felt compelled to see where we could pitch in on the emergency response, but in building relationships with our colleagues in local public health and in community organizations, we're just seeing so many parallels between some of the challenges we've worked on outside of the States and here, and we're, privileged to get the invitation from a number of those partners to really think about how we can start, as COVID, as the emergency, most critical kind of crisis phase was winding down, really think about longer term recovery work, but also really moving further upstream to address those fundamental drivers of what caused COVID to be such a challenge here in the first place. And so happy to speak more specifically about what that now looks like in terms of public health infrastructure. Community health workers are kind of an anchor component of our work around the world. And I think there's been a burgeoning movement here in the States around community health workers for a long time, but seeing some new momentum and opportunity there and that's a top priority for us that really bridges our domestic and work outside of the US. But I think, at maternal health, obviously we have a massive maternal mortality equity crisis in this country, and mental health are kind of a couple of the areas where we're particularly bringing learnings and programming collaboration opportunities across our different country sites. But I'll just say briefly as well, I think part of the interest for PIH in making a longer term commitment to a program here beyond our emergency work was really part of a broader commitment to support the movement for decolonization of global health, in terms of really helping to shift the idea about where expertise sits in the globe, where kind of knowledge and innovation comes from, and really kind of trying to put into practice or model what that can really look like to have our colleagues from Haiti or Sierra Leone really leading and driving accompaniment and advisory efforts here, programmatic work here, and how powerful that can be, I think was very motivating to us as well. I know I'm going on too long, so I'll just say the last bit in terms of the kind of ethical challenges or considerations that you asked about, Cyril. I think, we wanted to, as I said, always go where we're invited and, move at the speed of trust. We know there's a lot of extraordinary leaders around the country who've been fighting this fight for a very long time in terms of building public health infrastructure and more equity-based approaches. And so we really see our role, or kind of our approach, really centers on this idea of accompaniment. So we're not here to be out front or leading and driving kind of strategies and approaches, but rather to identify areas where we can come in and support the extraordinary leaders of state and local health departments, community organizations, community health worker associations, et cetera, and see what we can really bring to the table that is truly additive. But again, not to be in the driver's seat, but rather to say, where can we tap into new resources, networks, evidence, ideas that we can, add to the stone soup to kind of move work forward. And so happy to get more specific about that, but I think there's some real pragmatic questions there around, again, not displacing funding that should be going to frontline community-based organizations or into the public sector. That's sort of another core commitment that I think crosses our work globally, is really centering the role of the public sector in advancing the right to health as sort of the duty bearer of health as the state and not wanting to intercede in that, but rather to accompany and support government and community in leading the way and really just being that accompanitor in that process. So I'll stop there, but happy to chat more in discussion about any of those pieces.
Well, there's so many nuggets in there, Katie. Thank you so much. And I'm sure we'll come back to this in the Q&A section. You used a phrase I haven't heard before, move at the speed of trust. I'm going to internalize that. That's excellent. Thank you. So, Laurie, let me come to you. You're obviously the Chief Executive Officer of the National Association of County and City Health Officials. And NACCHO has been a super strong supporter of global to local initiatives, including developing a toolkit for local health departments and also facilitating a global health expert advisory board. What impact have you seen on these global to local initiatives? And why do you think they're so important? And as you're answering that, can you also include what are some of the best practices for international and local health organizations and considering how best to integrate initiatives that are developed globally as part of a local health department's portfolio?
Well, thanks for the questions. I think, for us, our foray into this area was really driven by some of the things I opened with, which is, we're not making headway in certain key areas in our jurisdictions, and we need solutions to our common problems. And so where can we look for those? How can we not reinvent the wheel and replicate some of these practices that work elsewhere that have shown to have better outcomes? And so through our, and I like to call it our global to local initiatives, we have really sought to raise awareness of among our local health officials and the staffs that serve these departments that there are practices beyond our borders that deserve a look and exploration, and try to raise a healthy level of inquiry and leadership among our health departments to begin exploring what it looks like to do some of this work in other places. We implemented 2 pilot projects as part of one of the arms of this work over COVID to really address local health departments and their need to deal with spikes in mental health and substance abuse and use disorders spurred by the COVID pandemic. And what we discovered was the global tools that we use from the World Health Organization in this case really helped to build local health department capacity to leverage non-specialist positions as key supports in a community to connect the community to behavioral health services. And the interventions that were used really kind of demonstrated the ability of non-clinical and non-professionals, peer-driven work to make quick mental health assessments while they're providing street outreach for the most at-risk populations. And it really created trust, as Kay said, which is essential for this work, and beneficial relationships between clinical and non-clinical staff members delivering services to these clients who were most in need of mental health and substance use services. So we are happy to say that those 2 examples really resulted in increased community outreach and increased, the bottom line is getting people to the services that they need in order to become well again. But we've seen diverse examples also in many other areas of the country. And I'd just like to highlight a few of those. In rural West Virginia, they utilized a South African HIV intervention that was related to mobile alerts for a syphilis outbreak. In Harris County, Texas, they utilized approaches from several countries, from Australia to Sri Lanka to Vietnam, to inspire vector control strategies for Zika, West Nile disease, dengue, fever, other mosquito-borne illnesses. In New York City, they use a Zimbabwe approach to place benches in areas of the city where mental health services were needed and not available, and they trained grandmothers to provide basic mental health services. So the whole of the community, as an example, in rural Alabama, they utilized a Cuban prenatal approach model to improve pregnancy outcomes for really high-risk pregnancies. So these things are being done, and our effort here was really to raise these examples and show that they can be used and adapted. I think in terms of considering how best to integrate the initiatives as part of a local health department's portfolio, NACHO created guidance for adopting and adapting global health approaches for U.S. local health departments to really help provide assistance to local health departments engaging in the process of adopting or adapting a global approach in the context of the communities that they serve. And the guide really breaks down adaptation into how to select a global solution whose elements can be adapted without really undermining the solution's effectiveness, how to adapt a program that ensures it best suits the needs of the community, how to diffuse the adapted global solution in the local community, and really, really driving at questions during utilizing this guide. Can the intervention be tailored to a worldview and lifestyles of population served? How might the language be updated to reflect reading and age levels of audiences that are intended? What other adjustments might need to be made in gender, racial, ethnic, religious, socioeconomic backgrounds and norms? What changes would be helpful to reflect the community's local ecological aspects, and the list goes on and on. So really trying to put in the hands of our local health departments a tool and a set of inquiries that they can use to really look at a practice internationally that's been successful and bring it here and adapt and adopt it to our local community. It's not easy work, by the way, because our cultures are very different, but we have demonstrated successes that it can be done. And so we're really excited about this work and really hopeful about the promise that it brings to help us change outcomes. So I'll stop there to allow time for others, but happy to explore any of that further.
Thank you, Laurie. One very quick question. Is there a sort of a one-stop shop or some site where one could find all these examples which you've mentioned that some of our audience can go to?
A lot of it's in our toolkit, and I'll put some links in the chat for you all in case you're interested in exploring some of those links further and delving more deeply into what I talked about.
That's brilliant. That's brilliant. Thank you so much. Thank you. And Kristen, you've been at the Washington Department of Health for 12 years. You were absolutely critical in setting up this transformational plan, which, from what I can understand, is the very first in the nation to envisage prioritizing global and One Health. I would love to sort of pick your brain on this. So can you share examples of first of all, more about why you prioritize this and why you felt that it was so important to advancing health for Washingtonians, and then some examples of best practices or learnings globally that you're working to incorporate here in the state of Washington.
Absolutely. Thank you. I do want to pause for a moment. Secretary Shaw may be on the phone and want to kick this question off. So I'll pause for a moment. All right. So I'll go ahead and get started on it. Yeah, thank you for that question. We are really excited about our transformational plan, which we dog interruption there, which we launched about a year ago. And it is really our effort to re-energize our public health efforts coming out of the pandemic. You know, we at the Department of Health have focused on Global One Health in various ways. We have a strong refugee and immigrant health program. We operate our state lab. So a lot of good work has happened for a long time, but we really realized during the pandemic that there's more that can be done. There's more innovation and creativity. We really need to think about community and how we respond to community needs and building that trust and thinking about what did work well during the pandemic. Certainly, it was devastating, and we are still building back from the impacts of the pandemic on many levels. But what did come out of it was really the realization that when we and thinking about the principles of a global health, we utilize a community based workforce to further our efforts, we can reach communities that we never had access to before. And I'm just going to pause. I think, this is perfect timing. Secretary Shaw is on, and so I can give my voice a little reprieve. Secretary Shaw, are you able to hear us?
I can. Can you hear me?
Yes, we can. Well, welcome, Dr. Shah, Secretary of Health for the Washington State Department of Health. We're halfway through this session, and we're delighted you're able to join us. Your flight landed on time, and we just asked a question about what does globalization look like in Washington State from a public health context, and what lessons you're learning as you implement work in Global and One Health.
Well, first of all, thank you so much for the opportunity, and I know I'm joining Kristen Peterson, so I know she has this all covered. So I'll do my best to at least just provide a couple of quick perspectives. Also, apologies in advance because I am out of town and just landed, and I am doing my best to make sure that I get to where I need to go without causing any global or One Health issues along the way. So we'll leave it at that. But I think, you know, this is a real it's a real honor to be able to join our colleagues at PATH and others, other partners across the spectrum. As Kristen either has said or was about to say, that we are very excited about our transformational plan that we launched in August of 2022. And of the 5 priority areas that we have, one of them is Global and One Health, and we are the first state health agency in the nation to have Global and One Health as one of its priorities. And we're very proud of that, but we're also very keen on understanding this interconnectedness of global and domestic health, as well as recognizing this multidisciplinary approach of humans, animals, and the environment. And so the reason I bring this up is that as we think about the ecosystem of health in Washington or across our state, we know this pandemic that all of us have experienced absolutely underscores why global and One Health, global and domestic health are intertwined. But at the same time, if we think about that, it's not just about a pandemic or infectious diseases, right? COP28 just was, is in our rearview mirror. What happens across the globe when it comes to global cooperation or lack thereof also has a significant impact on the people and the work that we do. So I think there's an opportunity for us to be thinking about the actions of players across the globe and how that impacts us here in Washington. And then really from the standpoint of cybersecurity or immigrant health, refugee health, there's so much that we have that comes into the global space. Obviously, with our 29 federally recognized tribes, there is also this underpinning of One Health of humans, animals, and the environment or the lands that we live on. And that is also such an important aspect of the work that we do at the Department of Health. And so when we bring this new global and One Health frame to the work that we're engaged in, it allows us to really be thinking about this multi-sectoral approach. And then the last thing I would say is partners like PATH and others, it's really about how do we work together ultimately to be thinking about this great ecosystem that we have of partners in our state who are engaged in global health efforts, who are interested in global health efforts, who understand and recognize the importance of those efforts as we continue to do our work. So let me pause there. I do think there's a lot to unpack here, which I know Kristen will be able to do markedly better than I can, but I'm just so supportive of Global and One Health efforts and the partners that it takes to really move the needle. And in fact, let me say one, if it's okay, one more thing.
Yeah, go ahead.
Which is that one of the reasons that we are so focused on global and domestic health and this intersection is that we oftentimes have this hubris, as we know in the US, which is we are going to teach the world. But there's so much in the world that we can learn from. And to take global practices, for example, health promotion, promotoras, community outreach workers, community health workers. How do we go community or neighborhood or home to be able to underscore health promotion efforts? The infectious disease efforts, where we learn from what's happening in one part of the globe to another part of the globe, tuberculosis prevention efforts, DOT efforts, directly observed therapy efforts. How do we do that more successfully? Oftentimes when we think about resource constrained environments, there's so much that mirrors what we are seeing across our state. And that's why we believe that global practices can help inform and actually improve the lives of Washingtonians, because we're learning from what other parts of the world have already learned. So I just wanted to underscore that last point. Thank you.
That's excellent. Thank you very, very much. Now, let me just ask, do you have a couple of minutes, or do you need to head off now?
I do have just about a few minutes, yeah.
Okay. Well, maybe what I'll do at this point is just ask if anyone has a question for you at this particular point. I have one, but I'll just open it up in case any of our listenership. We have folk who are literally listening in from all over the world and who are fascinated here. There's, of course, as well from the US. But I just want to, if you have any quick questions that you want to type into the chat, go ahead and do that. And perhaps whilst we're waiting, let me ask you, Dr. Shah, I mean, you've really painted a picture of a true, a truly bidirectional public health ecosystem, at least for the state of Washington. Where do you see the greatest need in terms of prioritizing? I mean, there's so many things, as you say, so many issues areas. Where do you see either the greatest need or the greatest opportunity of the multiple things that the transformational plan has, or the multiple things that you've talked about? Where is either the biggest need or the biggest opportunity, if you could reflect on that? And you might be on mute at the moment.
There you go. Sorry about that.
Great.
In our transformational plan, there's so much that is packed in there. Health systems, workforce transformation, learning from across the globe when it comes to environmental health and the call out to climate, emergency response and resilience building for communities and the people that live in those communities, and obviously global and One Health. But first and foremost is health and wellness. And there's so much that we have to learn from what's happening across the globe. There are so many nation states that have done such a masterful job of integrating this holistic approach to human health, the individual and the families and the communities within which those individuals live. And that is an integration piece that is so critical to the work that we can do. So I really think health and wellness, when you think about physical health and nutritional health, and obviously our emotional, behavioral, spiritual health, what is it that we can learn from others? In fact, just recently, some of our sister agencies and our governor's office had gone to Iceland to learn about the Icelandic model when it comes to approaching teens and youth for not just chronic disease prevention, but also healthy eating and healthy physical activity efforts. That is an example of something that's happening across the globe that we can apply here domestically. Another example I'll bring up from when I was in Texas. I will tell you, for example, we were working very closely with Microsoft Research and deploying, if you remember, Project Premonition, these smart traps for mosquitoes. And what it was really designed to do is the actual oscillation or the frequency of the mosquito wing flapping could decide if it was the Culex mosquito or the Aedes mosquito, and then trap it with this incredible amount of data analytics to tell us what was happening in the environment, so we can learn more about the context of that mosquito and then be able to predict disease patterns. Well, why was that important? Well, we were doing that in Harris County in Houston. Well, guess what? We learned that the traps were actually applied in Grenada first, and then after they were, or simultaneously working with our agency, they then went to sub-Saharan Africa to also see how it would be deployed there. So there was this learning happening across the system. But here's the one gap that I would just bring up to all of you. And this is a challenge. This is a challenge to all of our different partners. I've been involved in a lot of these efforts over the years of this intersection point of bidirectionality of global and domestic health. When we go to many of our partners that are involved in global health, they say, you know what? Don't bother me about domestic health here in the United States. We're not interested. That's not our portfolio. And then when you go to domestic health agencies, they say, you know what? Don't talk to us about global health. That's not part of our portfolio. So the challenge that I give to our partners, how do we bring that bidirectionality and that perspective of intersectionality of the work that all of us must be engaged in? Because all of us have to recognize that we are all part of being the global citizen or the global partner. And that is the big challenge, is that we see a lot of demarcation. And that's why we're so excited about being part of opportunities like this, or being a partner alongside the Washington Global Health Alliance, or doing the work that we're doing to help lead this effort across state and local public health agencies across the country, because we believe it's so critical to the work that we need to be doing moving forward.
Wow, lots and lots and lots of nuggets in there. Thank you so very much for taking the time, Secretary Shah. And we wish you a happy holidays and safe onward travel. We will reflect some more because we know you have to go. So we'll reflect some more whilst you get on with other things you have to do. But thank you for taking the time and for prioritizing this, because this is a very, as you point out, a hugely important topic for all of us and for all our listeners here.
It is my honor. It's my pleasure. And I will tell you that we are committed to continue to work with you. And I will be taking a global trip soon. So I just got back from one and I'll be taking one. So I tell you, this is an opportunity for me to learn as I'm overseas and also bring that back to help our domestic efforts. So thank you so much. Have a happy holidays and really appreciate the time.
Thank you. Thank you very, very much, sir. All right. So perhaps I can go to one of the questions that has been already placed in our question box. It says, what are the suggestions for global health in the present day competing environments of man-made disasters, and also the disparities due to the economics and the access to care? And that's from Shabina Hussain. Any one of the panelists want to take that? What are the suggestions for global health in the present day competing environments of man-made disasters, and what are also the disparities due to the economics in the access to care? Really two separate questions almost. Any of our panelists care to take that?
I can hop in here for a moment. I'm a little bit, I'm not sure I have suggestions for competing environments of man-made disasters. except that, you know, no matter what we're talking about here, there are opportunities to share our experiences. And I think we have to open up our opportunities for this bi-directional peer learning through, you know, hosting one another to other countries to learn more, to explore around interventions and practices and that sort of thing. But on the disparities, I really wanted to comment on that and say that, you know, we are not going to be a prime example of a country that knows how to deal with this, because we are one of the worst examples in the world of dealing with racial and other inequities. And those disparities still exist here due to economics and other socioeconomic factors as well. So I think that this is an area where we can definitely explore how others do it, but the challenge is going to be our healthcare systems and even our public health structures, because this country, you know, we know what some of the issues are, but we really don't have the tools or the political will in most cases to be able to address them. And we don't have some of the infrastructure and systems for being a highly developed country to actually deal with our public health issues here, you know. And, you know, so it starts here in our own territory with actually driving investment to public health that helps us to build our infrastructure and systems and data modernization and everything else that goes along with both understanding and addressing disparities. So not much of an answer, so much as a rumination around yes, I agree. Would love to hear from others if they have any true solutions, but we can't give up. I know that because
Absolutely.
the next pandemic or the global emergency or even domestic emergency is at our doorstep, and shame on us if we have the same outcomes that we had from COVID due to some of these deep disparities, and that's on us for not addressing them.
Yeah, definitely. Katie, look like you're about to say something.
No, well, I don't think it's a solution per se, but just to build on what Lori was outlining, you know, I think it's a really important question, and the sort of man-made disasters in this country of systemic racism, severe income inequality, you know, xenophobia. I mean, all of these are real profound challenges that we face, as Lori said. I think part of our thinking around how we address those, as you said, Cyril, it can't be you know, that it's an all or nothing until we can address all of those things comprehensively at once, you know, tools down, but rather we need to advance some of these incremental technical programmatic solutions, you know, today to move the needle, but really a lot of this is more of a political challenge for us, and really there's work to be done around movement building, around power building in communities, and around advocacy to really advance the systems change work and sort of the national conversation on making health a human right in this country, as well as, you know, housing and all kinds of other things that are required to really fundamentally change the kind of health outcomes we're talking about. So I just say, to me, that the kind of answer there is more in the kind of political advocacy organizing realm, and that's an equally important part in addition to the technical and programmatic work we have to do.
Yeah. And Kristen, I suspect you have a unique perspective because you may be able to talk about marshaling public health principles at governmental and state legislature level, and that sort of messy, curious interplay. Do you want to say a little bit about that?
Yeah, sure. Well, we are lucky to live in a state where climate and health is one of our governor's top priorities. So we have seen recent investments that may serve as a model in, for example, a Healthy Environment for All Act that we're implementing with other state agencies, which looks at environmental justice principles. So we are conducting environmental justice assessments on all new significant agency actions. We're investing in climate and adaptation principles. We have invested in a Washington tracking network where we are looking at environmental data and disparate impacts on certain communities. So I think it's exciting to see what's on the horizon and what may be transferable. But we're definitely at the cusp. And again, it is one of the pillars of our transformational plan, environmental health, with a strong focus on the disparate impacts of the environment on certain communities. And I hope that answered your question.
It did. It did. Thank you. Thank you for that. So all too soon, I see we only have about 4 minutes left. So just again, to give our panelists the most amount of time to sort of share any closing thoughts that they've had, I'll ask you each in turn to perhaps spend 30 seconds to a minute just sort of reflecting on something that you want us as your audience to take away with this. Katie, perhaps I can start with you.
Sure. Well, I'll use your words, Cyril. So many great nuggets from this conversation that we could build on, but maybe just one thread I think we've highlighted throughout everyone's remarks, I think has been around, in particular, the opportunity to learn from global colleagues and partners around the role of the community-based workforce, community health workers, promotores, really in advancing equity as such a critical cornerstone and an area, I think, where we have a lot of great momentum right now in this country and a lot of opportunity to keep pushing both legislatively, programmatically, funding wise. So happy to share some resources about the work we're doing with the National Association of Community Health Workers here in the US and with a number of state and local partners. But I just offer that as an invitation as an area that I think there's a lot of need, there's a lot of momentum, a lot of opportunity right now, and would love to see some more coalescing of global health colleagues in support of that movement here in the US this year.
Yeah, thank you, Katie. And what we might do, if it's okay, is sort of have you share some of those resources with us, and then when we make this sort of broadly available, others can take a look at that, if that's okay. Thank you very, very much. Laurie, so last closing thoughts.
I would say, I think a barrier for many people, whether you're in the United States or outside of the United States, to learning from other places is that it seems overwhelming. And I think what I'd like to leave people with is it can start really small. I mentioned a number of very small initiatives that hopefully will be the impetus for some of these local health departments to explore other areas. And I would just say, just be open to the possibilities beyond of what you know and are familiar with, to learn from others and to open yourself to those ideas that might seem strange to you coming from other places, or might not seem doable, but they really can be adaptable and adoptable here and elsewhere. Just openness to those possibilities and really thinking outside of your maybe comfort zone and addressing some of these larger issues of the day and really exploring what we may be able to gain from others.
Thank you very much. And Kristen, you have 30 seconds to have the last word.
Okay, thank you. Yeah, Laurie, that reminds me of the quote that sometimes innovation also means simplifying our approaches. And coming from the state perspective, how do we create more accessible programs and services? But, it does take all of us, like Dr. Shaw said. I mean, the successes we saw coming out of the pandemic were due to mobilizing community-based workforce, mobilizing mobile health. We launched our first ever caravans, which had more than 2,000 events, getting vaccines to typically hard to reach communities. And we're going to continue that effort. And then centering community. We convened more than 700 community leaders during COVID-19, and we've continued that collaborative So we get input and feedback and co-design with community programs and initiatives that reflect their needs and values. So it is that shared power, which I think Katie alluded to at the beginning of this session. And we just look forward to the partnership with all of you and continuing this dialogue. Thank you.
Thank you. Thank you so very much. To our three panelists, Katie, Kristen, and Laurie, a huge, huge appreciation from all of us. Thank you again, and we'll be making these conversations and this recording available to all in the fullness of time. Thank you again, everyone. Have a wonderful rest of your day. Bye-bye.
Thank you. Bye.
Bye.
Thank you.